Hello everyone, this is Michael Ibrahim. I'm presenting today the Mr. Garcia case. So Mr. Garcia is a 57 years old Hispanic man with main complaint of cough, fever, shortening of breath, throat smell of breath, decreased urine frequency in the last 24 hours, stopped his medication since then, and he hospitalized yesterday. Past medical history for Mr. Garcia is gonna be heart failure, diabetes mellitus type 2, primary osteoporosis, allergic rhinitis, essential hypertension, social history, former smoker, no alcohol, live with wife with two grown kids, worked for an insurance company, family history, father with history of hypertension, depression, and anxiety, and died with MI. Mother history of hypertension, diabetes, dies with lung cancer. Sister alive, 69 years old with hypertension. His diet, he eat as home cooked meals for dinner and fast food for lunch, reduced to 2 times per week. He good with salt. However, his wife noted increased salt intake over the last week. Exercise, walk for 10 minutes at lunch 1 to 2 times per day. His current medication, metoprolol succinate 100 milligram a day, atorvastatin 40 milligram a day, furosemide 20 milligram BO every day, lisinopril 10 milligram a day, spironolactone 25 milligram a day, potassium chloride 10 milli equivalent PRN over 1 hour for serum potassium less than 3, and insulin regular IV continuous infusion of 5 units per hour to keep glucose less than 180, starting with hospital admission. Cefepime 2 gram every 8 hours IV, vancomycin 2 gram every 8 hours IV, metronidazole 500 milligram every 8 hours IV. All that start with hospital admission yesterday for just 2 doses. Doxycycline 100 milligram BID BRN for constipation. Acetaminophen, dextromethorphan as needed for shortening of breath, and no known allergies. The my prioritized problems is gonna be CAB and DKA, ADHF, pain, and AKI. All is acute with high priority, and all others is chronic with low priority. I'm gonna start with Mr. Garcia CAB. So assessment of the disease is gonna be according to IDSA guidelines. Mr. Garcia is suffering from severe uncontrolled community acquired pneumonia because he has 3 minor criteria, which is leukopenia, uremia, and confusion, and he not hospitalized the last 14 days. The pneumonia severity index is 167 points, which is class 5, because it's more than 130. CURB 65 criteria is a score 2. So according both of those two, he should be treated inpatient. And the risk factor, he have congestive heart failure, diabetes, and neutropenia. His lab shown up gram-positive cocci in chains, MRSA nasal negative, Legionella streptococcal urine bending, sputum viral PCR negative for influenza and common viruses. Excuse me. Cardiologist shown up diffuse bilateral suggestive for pneumonia, risk factor of infection with resistant S. pneumoniae, diabetes, and heart failure. Goals: eradicate infection, relieve symptoms, and provide supportive care as needed, prevent disease progression and complication. Assessment for therapy: continue acetaminophen, dextromethorphan, stop empiric treatment for cefepime, vancomycin, metronidazole, because the culture returned negative for MRSA, so you need to get vancomycin. and it's a gram positive for cocci in the chains. In addition to IDSA CAP guidelines not supporting anaerobic coverage unless patient has lung abscess or empyema. My plan for Mr. Garcia is gonna be according to IDSA CAP guidelines: ceftriaxone 2 gram IV every 24 hours and azithromycin 500 milligram IV every 24 hours. That's most recommended and no renal adjustment needed. On my contingency plan, I'm gonna change the azithromycin to levofloxacin 750, and all of that according to the sensitivity text when it comes back. And patient should show clinical improvement within 48 to 72 hours. And according to IDSA CAP guidelines, not supporting steroid use for that patient. Non-form treatment, bed rest, humidifier, adequate nutrition, chest physiotherapy, supplemental oxygen, ventilation, and vaccine gonna be Pneumovax 23, Haemophilus influenza type B, influenza vaccine, COVID-19 vaccine, hepatitis B vaccine, monitoring for efficacy, clinical improvement in 48 to 72 hours, signs and symptoms of infection, white blood cell count, oxygen level, monitor for safety, urine analysis, BUN, serum creatinine, liver function, skin rash, neutropenia, leukopenia, postmortem time, and diarrhea for sure. Patient education patient about C. diff, watery diarrhea, and how he should contact the doctor if he gets this one not treated with antidiarrheal medication. And if he get any rash, he should contact his provider. For the DKA, assessment of disease is gonna be according to ADA guidelines. Mr. Garcia suffered from uncontrolled moderate DKA because he have low CO2, which is 26. Lung are compensated. The blood glucose is 380. Low pH 7.12. Bicarbonate is 11. All of that refer to moderate DKA. In addition to an anion gap of 20, which is more than 12. The corrected sodium come to 133, and anion gap is gonna be 20. He has metabolic acidosis, mental status, drowsy, fruit smell of breath, and the participating factor is infection, gram-positive cocci, antibiotics, SGLT, which lead to euglycemia, DKA, and he not taking his medication for 2 days. Patient is hypervolemic and hyponatremic. The goal is stabilize the patient case and treat the fluid overload and improve renal perfusion, correct fluid deficit if needed, normalize fluid and treat ketoacidosis and electrolyte imbalance, and relieve all other participating factors. Assessment of drug, it's gonna be the fluid replacement wasn't appropriate because the patient is overloaded already and he already get 2 liters of normal saline in ER. Need anticipatory potassium replacement cut up to increase from 3 to 3.3 because we cannot get insulin infusion while the potassium less than 3.3. So my plan for Mr. Garcia gonna be according to ADA guidelines: hold SGLT2 because that's lead for euglycemic ketoacidosis, and we should stop offending medication. Hold insulin until patient potassium come more than 3.3 to avoid life-threatening arrhythmia due to low potassium. When the potassium become greater than 3.3, restart insulin, but in a different regimen, which is 0.1 unit per kg bolus, which is 9 unit bolus and 9 unit per hour as a continuous infusion, while giving 20 to 30 milliequivalent potassium in each liter of fluid if we need that as a maintenance. Use regular insulin because it's short half-life and easily treatable. Titrate to effect, decrease glucose by 50 to 100 milligram per deciliter per hour, and decrease infusion until it gets a steady state, and that's to avoid cerebral edema. When blood glucose less 200 milligram per deciliter, we can add dextrose D5W for the regimen. If the patient, because the patient is hypovolemic, hyponatremic, fluid and sodium restriction is preferred treatment. Loop diuretic can use for in severe cases. Hemodialysis is an alternative, so that's gonna be my contingency plan to do the hemodialysis. No benefit use bicarbonate for acidosis unless pH less than 6.9 by ADA guidelines. Monitoring for safety and efficacy, glucose every 1 to 2 hours. Make sure not to do drop quickly, and potassium every 4 to 6 hours. Anion gap, chemistry 7, electrolyte, ketone bodies, and acetone. Patient education for hypoglycemia, hyperglycemia symptoms, how to monitor blood sugar, importance of vaccination, importance of use a statin, refer to a nutritionist and the podiatrist, exercise regimen, etc. For the ADHF assessment of disease according to ACC guidelines and HF Society of America, Mr. Garcia has uncontrolled ADHF subset 4, congestion and hypoperfusion, cold and wet, hypovolemia, hypernatremia. Patient has poor capillary fill, cold to touch, blood 3 betting edema, blood JVD 6 centimeter, blood S3, S4, chest X-ray, shown that as well, normal blood pressure. Goal of therapy, control symptoms, improve quality of life, patient education, prevent hospitalization and mortality. Assessment of drug, oral furosemide is inappropriate because according to HF Society of America, it is recommended that patient with fluid overload be treated with intravenous loop diuretic, not oral. That's strength of evidence B. So I recommend to stop oral and start IV. Stop lisinopril because that worsens the AKI. Continuous metoprolol, spironolactone, and potassium treatment. My plan for Mr. Garcia gonna be according to ACC guidelines and HF Society of America. Loop diuretic is recommended for fluid overload to treat by intravenous. As I said, it's evidence B. According to those studies, there is no statistically difference with regimen of continuous infusion or bolus, and not low intensification or versus high intensification, which is 2.5 of the oral dose. So I'm gonna start by 20 milligram BID, bolus IV. In patient with hypovolemia, fluid and sodium restriction is preferred treatment. It's gonna be hemodialysis as my contingency plan. Inotropic, because the patient blood pressure is 120/85, no need to use inotropic unless the systolic blood pressure less than 90 for refractory cases. If it's not, if that case, it's gonna be my contingency plan as well for melatonin, 0.1 to 0.5 mcg per kg per minute, and need renal adjustment. Vasodilator, I'm gonna start nitroglycerin 5 to 10 mcg per minute, titrate every 5 minutes, and titrate down in case of headache. Stop lisinopril until the AKI resolved, and start then interest to make sure to have a washout period of 36 hours at least. Continue metoprolol and atorvastatin, spironolactone, potassium. As I mentioned, the monitoring is gonna be system relief, vital signs, blood pressure, weight, edema, kidney function, chemistry, heart rate, ECG, dyspnea, urine output, and fluid intake. Patient education, educate about how to use the heart failure action plan. Stop medication. Don't stop medication without contact your provider. Contact your provider if something getting worse. Important of vaccination and education about blood pressure monitoring and waiting every day. Thank you, and have a good one.